of introducing Dr. Heli Bhatt. Dr. Bhatt joined our division this year as our second pediatric hepatologist. She completed her medical school training in India and then traveled to the United States, where she received her MPH at the University of Texas Health Science Center in Houston before starting her residency in pediatrics in Tucson, Arizona. After residency, she went on to Riley Children's Hospital in Indianapolis for a pediatric gastroenterology fellowship, and then completed her advanced hepatology fellowship at Washington University in St. Louis. She has a special interest in liver disease and autoimmune hepatitis, and today she'll be presenting her talk titled Coagulopathy and Liver Disease. Thank you, Dr. Bhatt.
Thank you, Katie, for that wonderful introduction. Let me share my screen here. All right. So thank you, Sarah Jane and the Department of Pediatrics for giving me this wonderful opportunity, especially so early in my career. I'm really excited. I also want to extend a special thanks to Marie Steiner, who helped me perfect my presentation. And with that, I'm going to dive right in. So the presentation today is mainly focusing on coagulopathy and liver disease. And excuse me, I chose this topic because this is not a commonly talked about topic, but it is a very commonly faced challenge in all types of decompensated liver patients, whether it's acute and chronic liver failure, or it's acute liver failure, or sometimes just decompensated chronic liver patients. I do not have any disclosures, though I would definitely like to mention here a lot of the data in my presentation comes from adult studies, because there is a significant paucity of data in pediatrics. There is a couple of little things that we can extrapolate from our adult colleagues and apply to pediatrics, but there needs to be way more studies done in pediatric age group. So the objectives today are basically, understanding the complexity of hemostasis in our body, understanding the role of liver in regulating that, and how a dysfunctional liver affects it. I want to stress the importance of all the tests that we do and how to interpret them in management of this disease. I do wanted to mention that management of bleeding or clotting complications in liver disease is not the focus of this topic, because that could be a whole different whole separate grand rounds in itself. And so that's not the focus of this presentation, but I do want to impress upon all of you how complex this the situation can be when your liver goes haywire and starts doing all the stuff that it does when it's sick. So, talking about the basic mechanisms of hemostasis, it can be divided into primary and secondary hemostasis. The primary hemostasis is basically plugging the area from where the bleeding is happening. So you have your platelets, which form a nice platelet plug in combination with fibrinogen and von Willebrand factor. And once that is made, there's like more stuff, more fibrin that comes and makes that clot stronger. In normal human body, there's a lot of little, wear and tear going on, and this little platelet fibrin plugs keep forming, and then your body naturally just breaks them, and that's fibrinolysis and clot degradation, so that you don't keep clotting uncontrolled. Once that part is done, and if you did not just have a regular wear and tear, but you were actually bleeding, your body kind of starts this whole coagulation cascade, which can be divided into intrinsic and extrinsic pathway. And I know we all learned in details about this in our medical school, but the important thing to remember is the factors that are affected by the liver. So 2, 7, 9, 10. We always talk about this. They are affected affected in, both the pathways, but the extrinsic pathway is just dependent on factor 7, which is, liver mediated. We a lot of times don't talk about protein C and S, and we'll talk more about it, but I just wanted to point out that those are actually opposite of factors 2, 7, 9, 10, and so there's this whole balance that gets affected. And then, just like I talked earlier, fibrinolysis, which is important to make sure that you don't overclot and you don't coagulate different vessels in your body. And this is really important as well. So what is the involvement of liver? Liver is an important site for synthesis and metabolism of these clotting factors. It is also a site for synthesis of inhibitors of coagulation, and it also helps in clearance of all the activated factors, the fibrin degradation products. So so these 3 parts, they are really affecting all 3 levels of hemostasis, and liver kind of plays a role in all 3. So you can imagine when your liver is not functioning well, everything is going to be affected. So what happens in a diseased liver? This picture is a little busy, but it's really important if you see that first and foremost, the coagulation factors and platelets are reduced in liver cirrhosis. So then there's decreased clot formation. But then again, the inhibitors of coagulation and fibrinolysis are also reduced. Thus, it favors clot formation, one versus other. Then there's decreased synthesis of everything, pro and anticoagulant factors. There's also portal hypertension, hypersplenism, thrombocytopenia. There's some thought that even though the platelets are decreased, their activity is increased. It's not clearly studied or proven, but there's that thought. And then, of course, you have this endothelial injury, which releases all your 1 Willebrand factor, factor 8, which can also change the balance. So it is a pretty complex system and gets very dysregulated when your liver is not functioning well. What happens? So this is a great slide. I feel like it discusses what problems happen in chronic liver disease in different phases of hemostasis. So when it's primary hemostasis, the platelet vessel wall interaction, you have low platelet, but then you have high von Willebrand factor and low ADAM TS13. But then when you come to the next step where it's coagulation, you have both low anticoagulant factors and low procoagulant factors. And then the third step of fibrinolysis, you have low plasmin inhibitor, which is huge, but then you also have low plasminogen. So it plays a role in both pro-hemostatic and anti-hemostatic drivers. So in your body, normal hemostasis is a balance between antithrombotic mechanisms and prothrombotic mechanisms. And when both of those factors are in good volume and they're functioning fine, you remain in a nice balance. When you have a compensated chronic liver disease, your balance gets a little modified. And so we call it rebalanced hemostasis. The issue comes when this little balance topples and we don't know which way it is going to go. This slide is super busy, and by no means do I want all of you to go through everything, but it just signifies that how complex the hyper versus hypocoagulability and the balance in liver disease is. And then on top of it, you add medications, you add other comorbidities, you add kidneys, and in adults, you add alcohol, and kids, you add infection. It's just, there's just no way to predict which way this is going to go. So how do we predict which way this balance will lean? How to correct this? I was practicing this presentation in front of my daughter, and this was her face, which I think a lot of your faces would be right now as well. So I wanted to touch base about or talk about some of the studies that have been done in adults. This one was a systemic review and a meta-analysis to just to see what is the risk of venous thromboembolism in patients with cirrhosis. And there was very clear evidence that the risk of thromboembolism is higher. The first figure shows venous thromboembolism. The second one is deep vein thromboembolism, and then pulmonary embolism. And as you can see, the odds ratio leans in the axis of 1 for all three of them. There's also an increased risk of portal vein thrombosis. It is only 1% in compensated cirrhosis, but it increases very fast, and it's about 8 to 25% in those awaiting liver transplantation. The pathophysiology for this is kind of an imbalance between everything that I talked about, and the Virchow triad plays an important role in that. This is really important because it's even more exaggerated in pediatrics, especially with low vessel wall, and they are slightly hypercoagulable than in general than adults. And so on top of it, you add systemic inflammatory response that happens in liver injury. The flow velocity decreases due to intravascular volume depletion. There's imbalance. Then these tiny vessels get injured. It's even more exaggerated in kids. Of course, there are no studies to prove this, but one can apply their pathophysiologic understanding to kind of imply this. In adults, low molecular weight heparin has shown to be relatively safe to be used in pre-transplant patients. Of course, this needs to be used carefully, especially if you have renal issues, and I will talk a little bit more about this in a further slide. We have always talked about disseminated intravascular coagulation in liver disease. A new term is coming into play right now, and in compensated liver disease, or where there's not, where it's not just decompensating really fast, we use the term called accelerated intravascular coagulation and fibrinolysis. And this term is used for more like a compensated DIC. Now, when you start having more and more consumptive coagulopathy, it becomes decompensated, and then it becomes the real DIC. The biggest difference between ACIF and DIC is factor 8. And when the factor 8 increases, you start having the consumptive coagulopathy, and it can get out of control very fast. This, as a hepatologist, this area of study is very intriguing to me, and would be to a lot of you. There's this theory that liver fibrosis is driven by a lot of obliterative microthrombi in the liver, and the coagulation inside the hepatic vasculature, or the coagulopathy inside the hepatic vasculature, drives this. It has been shown in a lot of murine models, but it has not yet been proven in children. However, we all know that the outcome for liver transplantation in kids less than 5 kilos is not as good as bigger kids. Also, the waitlist mortality for those kids is higher. And so if there is something we can do to slow this progression and make these kids grow, it will be very helpful. I feel like this might be an area where we can have something to, decrease the progression of your end-stage liver disease or liver fibrosis, and help buy us more time to kind of make them bigger and have a more successful transplant outcome. It was also shown that low molecular weight heparin was helpful in those rats, and it prevented that hepatic fibrinogenesis for the same. Whenever talking about any about high INR or a kid or a patient with chronic liver disease, which is especially who is admitted with decompensation, we always worry the most about variceal hemorrhage. I wanted to stress here that variceal hemorrhage is more driven by the pressures rather than the number of INR or the amount of platelets you have. And so it's way more portal hypertension related. Hemostasis is not that big of an issue, especially in preventing variceal hemorrhage. Variceal hemorrhages, gastroesophageal varices are present in approximately 50% of patients with cirrhosis. And then it can increase to almost 85 to 90% in decompensated patients. They also progress from small to large at around 10% per year. Variceal hemorrhage, it occurs at a rate of around 10 to 12% per year. And like I said, it depends a lot on how hard your liver is and how are the pressures going through them. The 6-week mortality for this is 10 to 25%. So it is a significant risk, but it is not driven by the dysregulation in the hemostasis in your body. Now I'm going to change gears and talk about some of the common tests that we do, especially the INR, platelet, fibrinogen, etc., and try to stress as to how each of them helps us or does not help us. PT-INR, prothrombin time, and its international normalized ratio are something we very commonly measure and monitor. It measures factors 2, 7, 1, 2, 5, 7, and 9, 10. It does not measure the deficit of protein C and S, like I mentioned earlier. It is normalized against warfarin-treated and commercially available thromboplastin reagent, and there's a lot of variation between labs, and so instead of actually focusing on the prothrombin time itself, we focus more on the INR, or the normalized ratio for that. There used to be a very common practice of giving fresh frozen plasma to correct INR, but more and more evidence has come forward where it shows that the volume of fresh frozen plasma actually does more harm than help by decreasing the INR. Of course, there are risks associated with giving any blood product, like lung injury and infection and a lot of different stuff, but the volume is a very big issue in kids with liver disease, and it worsens portal hypertension. And I just mentioned to you that the variceal hemorrhage, the really devastating or fatal complication that can happen in these patients, is driven by the pressures. So it is important that we maintain the pressures as low as possible, and giving FFP just increases that pressure. And so we do not usually recommend correcting INR with that much volume of FFP. PT-INR is poorly correlated with bleeding post-liver biopsy. It is poorly correlated with any sort of GI bleeding in end-stage liver disease. It also increases the volume given during liver transplantation, which can be really hard to manage, especially post-transplant, since these patients are already volume overloaded and they need a very, very, very fine balance between in their fluid management post-transplant. The other thing is, there's all of these data came from adults, and that is just important to know. So here's the conundrum which we all face. Is my cirrhotic patient anticoagulated? Well, yes, because they have elevated INR, and that is a result of coagulopathy, but does that protect them against thrombosis? Well, not really. And so unfortunately, patients with chronic liver disease, it's like bad news because you're coagulated, but more bad news because that anticoagulation does not really help you against thrombosis. There is very good data to remind us that thromboprophylaxis is highly underutilized in patients with cirrhosis. CHEST guidelines recommend using either low molecular weight heparin or unfractionated heparin or any other modality of thromboprophylaxis in any patients that are critically ill and immobilized. However, there is very clear data to suggest that this has not been used routinely in chronic liver disease patients because we are worried about low platelets counts or high INR, which is reassuring to us, and or we are more worried about bleeding complications because they're more devastating to the eye. However, there's been numerous studies which show that anticoagulation is safe. It is effective in preventing thrombosis, and it should be used in patients with chronic liver disease. This paper talked about different types of anticoagulants that can be used in cirrhosis. And by far, if your patient does not have renal failure and does not need very rapid correction or reversal of anticoagulation, low molecular weight heparin is very safe. So the problem is, of course, using it in renal failure. The other options like warfarin, and they're just not as safe and not as controllable, especially when you cannot trust your INR, whether it's coming from using the drug or your liver disease. It's just hard to use them. And then the newer direct 10A inhibitors, we just don't have enough data at this time to recommend against or for their use. Then that brings us next to the other test that we very commonly, obtain and monitor, and that's the platelet counts. Platelet counts can be low in liver disease due to a multitude of factors. It can be because the platelets die earlier due to the inflammatory response. It can be due to splenic sequestration. It can be because there's low thrombopoietin and you're just not making enough platelets, and your bone marrow response is lower. And then there are medicines that you add to it, like you could have HIT from using heparin. So there's just multitude of factors that affect platelets in liver and not just portal hypertension. However, what we don't consider while just looking at the platelet count and thinking about their bleeding risk is that they have other factors. They have elevated von Willebrand factors. There's this thought about platelets are activated and functioning a little better, and then their hematocrit and the platelets can be marginated because of high hematocrit. So there's other factors that play a role in this as well. And then fibrinogen level, which is emerging as more and more commonly used and corrected lab that we follow. Most of this data comes from trauma patients, though. It has not been studied as well in liver patients, though physiologically it makes sense because it is mostly synthesized in liver, can be measured accurately, and its half-life is longer than other factors. It is shortened in cirrhosis, and so it would make sense to monitor this. However, I would like to stress that that replacing a cryoprecipitate, and I'll talk about what are the contents of FFP versus cryoprecipitate in an upcoming slide, can be used for repletion, and it's a smaller volume compared to FFP and won't drive your portal hypertension in the wrong direction. So that brings us to this new era of using viscoelastic tests. I want to preface by saying AGA came up recently with guidelines for management of bleeding and coagulation in liver disorders. And their very first recommendation was This is still, the parameters for different viscoelastic tests are still not standardized in liver disease. However, I want to stress that it might still be helpful, more helpful than INR or platelets in managing these complex patients. What does these tests do? It shows us a dynamic change, or what is actually happening in different stages, like all 3 stages of hemostasis. So like clot formation, its strength, its stability. It is more physiologic because it does not just measure one parameter, but it actually shows what is the interaction between different parameters in your body. It is a point of care test, and it can be used in real time. You just need your lab to cooperate with you. And in the past, when I have used it, that has been a bigger issue because we get the parameters, but we don't get the actual diagram, which is way more helpful than the actual numbers. Different commercially available tests are thromboelastography, or TEG, rotational thromboelastometry, which is basically TEG, but a little different mechanism and a little different parameter descriptions that they have. And then sonorometry, which is not available commercially at this time. Drawback, just like I said, the parameters are not defined in cirrhosis. They're not yet defined in children, but the tracing can be very helpful to us. So this is an introductory slide for those of us who are not very familiar with thromboelastography. The first figure, or the diagram, is actually the most helpful. The red line, or the reaction time, is actually the time taken from beginning of the clot formation to fibrin formation. The K, or the purple, the angle, is actually shows you how stable that is, and then eventually it follows into fibrinolysis and how that clot is broken down. The table next to it shows you what each of these things signify. So reaction time, or R, is measured in minutes, and it is, just like I said, coagulation cascade until initial formation of fibrin. The K time is the time between formation of fibrin to actually maximal clot firmness. The angle is the rate at which this firm, nice clot forms, and the cross-linking between all the fibrin and different factors. And then the maximum amplitude tells you how strong the clot is, or the maximum clot strength. And then the coagulation index will give you an idea of whether the patient is tilting more towards hypo or hypercoagulability. There is also, one thing is not mentioned in here, there's also lysis index, and that gives you an idea of how good or bad the fibrinolysis is. And then last but not the least, there are a couple of modifications of this test where you can actually look at how your fibrin is functioning, and you can also map your platelets to see how they're happening. They are more specialized than just basic TEG or ROTEM, but you can get it depending on what's available in your lab. This is a little more in detail, kind of the same thing, and more so this is comparing TEG and ROTEM, and as you can see, the terminologies are slightly different, but what they signify is really the same thing. So just like I was saying, the tracings tell you way more, a picture speaks more than words, and the tracings speak more than what the parameters tell you. So a normal TEG, or normal coagulation in your body, should look like the very top figure, where you have a nice in brief R time, and then your angle, or the rate at which the clot is forming and stabilizing, is very smooth, and it reaches nice maximal strength and stays the same for a long period, and then eventually tapers and your clot starts lysing. When you are on anticoagulants, or you have hemophilia, you take a long time. Your platelets, your initial clot is formed, but it takes a long time to get that fibrin clotting started. Then you're on platelet blockers, that R time decreases. when you're fibrinolysing a lot, you can see that your clot, it does reach maximal clot stability, but it doesn't stay that because your body's just like breaking it up. And then when you're hypercoagulable, you just clot really fast. And then it's like really strong clot, and it doesn't really break down. And then when you're on DIC, you can see that you kind of clot really fast, and it does reach the level that it should, but then it starts breaking really fast. So it's kind of very haywire. And the stage 2 DIC is really not something you want to see, because that's when it's all out of your control, really. So this diagram has been my go-to for a lot of management for bleeding / clotting complications in really sick liver patients. And it compares both the tests, whichever one you're using. For simplicity, I'm going to refer to TEG because that's what we have been using more from where I trained. And so your first and foremost question, how fast is your body clotting? So is your R really long? So are you, having delayed clot formation? And how do you fix it? You can give either fresh frozen plasma, which is basically your plasma and has everything that your plasma contains, but it's a large volume. Or you can actually give prothrombin complex concentrate. This is a new thing that's coming up. It is way less volume, but we don't know how it affects. We still need more studies for that. So that is how your R, if prolonged, can be treated. Now, if R is normal, what do? You look at your maximum amplitude or the breadth of your bar, the horizontal bar, and that indicates how strong your clot is, how your fibrin deposition and the cross-linking happened. So is it too low? Yes. That means that either fibrin or your platelets, one of them need better functioning. And that takes you to the next step where you can actually measure the functioning of your fibrin, or you can do platelet mapping and give corrective factors accordingly. Now, cryoprecipitate has way more fibrinogen compared to fresh frozen plasma in less volume. So it is a denser version of that. And in liver disease, we would prefer cryoprecipitate rather than FFP. And then if your maximum amplitude is fine and your clot is strong enough, you want to see how long does it last. So is your body just eating up the clot really fast, or not so much? And if it is, then you can use things like EAC or tranexamic acid, though we as liver doctors were very excited about this, but just very recently an article came in Lancet which has not been very promising for the use of tranexamic acid in liver disease. This is a busy slide, and I'm not going to go in details with this. I just wanted to mention this here in case any of you are interested in knowing what we know about the parameters in acute and chronic liver failure. Like I said, I rely more on the TEG tracing rather than the parameters per se. So, excuse me. That brings us to what is known in children, and can we use these viscoelastic tests in children? I once again stress that we really don't have too much data in children. And we know that there are 8 specific differences in both pro and anticoagulants in children. How are these viscoelastic tests affected? So the kaolin activated TEG, there's no difference. And that was one of the reasons why it was adopted by our lab at where I trained. The cellite activated TEG can falsely indicate hypercoagulation state for infants. And then ROTEM can also indicate more of a hypercoagulable state for 0 to 3 month old children. This has been a really good study that was published in 2018. It measured thromboelastography parameters and compared it within different comorbidities that can happen in liver disease to see how our regular factors or regular tests work in different, comorbidities versus how does the TEG or parameters work. So this first slide is how did TEG help us in sepsis. So as you can see, INR, platelets, PT, APTT, they were not really helpful. Their p-value was greater than 0.5. However, the K-time, alpha angle, and maximum amplitude, so how strong your clot is and how fast you're clotting, was actually really helpful in kids with kind of to indicate your risk of bleeding versus coagulation in sepsis versus no sepsis. Similarly, in acute kidney injury, our time and lysis at 30 minutes were really helpful, and the INR and platelets, not so much. And most importantly, the thing that we're worried about the most, the GI bleeding. Yes, the PT and INR were maybe a little helpful, but you can see the maximal amplitude and lysis at 30 minutes were pretty significant. And if you're fibrinolysing or breaking your clot really fast, your risk of bleeding is higher. And that's why you can see the very last line, the percent of lysis at 30 minutes was very, very strong predictor of your GI, you bleeding in the GI bleed in chronic liver failure. This TEG, it basically, my first experience with TEG was actually around liver transplantation, and there is very clear data to show that the amount of FFP, or the fresh frozen plasma, used perioperatively during orthotopic liver transplantation it decreases the use of that and hence helps the volume overload post-transplant. There's also newer work coming out for acute liver failure, and it also helps in the same. So, in summary, there are some take to work points, because I really don't want you guys to go home and think about this, but when you come to work and see a patient with liver failure who's having, dysregulated coagulation, there are a couple of things that we need to erase from our mind, and that is end-stage liver disease is characterized by decrease in procoagulants and increased risk of bleeding. I hope I stressed to you that thrombosis occurs equally, if not more frequently, than bleeding. Also, INR, while extremely helpful in telling me how your liver is functioning and what is, how good of a functioning and prognosis of your liver is, it tells me nothing about your risk of bleeding. Things to kind of remember or learn is, just like I said, thromboembolism occurs equally, if not more, compared to bleeding, and viscoelastic tests are the way to go in future. And my daughter was really happy after she learned all these things. Thank you, and I'll be happy to take some questions.
All right, thank you, Haley, for that very interesting talk, and just reiterating that it's a complicated process, and we can't totally rely on the labs in liver disease. So people, you can feel free to put comments either in the chat or question and answers. I will start with a question that kind of came up for me as we're thinking about children with chronic liver disease and higher risk procedures, so things like banding and that. Is there anyone that's using kind of the tags beforehand to consider what products prophylactically to give or things like that? Is that a worthwhile thing?
So there is no data for that. I would refer you to the AGA guidelines, which kind of is really good. It gives a really good and thorough review on that, and they recommend kind of arbitrarily having your platelets greater than 50, but really INR did not help at all. And so I have personally not seen a study or used TAG prior to, but it might be an interesting thing to, look at.
And so Dr. Naglio is wondering, is there a role for the measurement of factor V in determining synthetic function of the liver?
No, factor VIII was more helpful. Factor V was more helpful in prognostication, but not so much in giving us an answer which way you're leaning. Yeah.
And I think, yeah, and so sometimes, we often will use kind of our factor V and 7 and then 8 in acute liver failure, especially, I think. And but it sounds like in chronic disease, it sounds like not as much utility for it.
Yeah, it'll give you a good idea as to how good or bad your liver is, or how much whether you'll need transplantation or not. It's specifically for indicating whether you're coagulating fine or you're going to bleed or which way you're going to lean, not as useful. The factor VIII is useful because it's more like a panic thing in my mind, because it tells you whether you're going from the ACIF, which is like compensated DIC, to actually going towards DIC. And so factor VIII is something that'll help you, that you're getting into panic mode.
Sounds good. And Dr. Lowen, one of our HEMONC fellows, asks, if you are suspecting liver failure, how soon should we consider starting Lovenox for prophylaxis?
Yeah, so this is a good question. I have personally not started Lovenox on any of my patients yet. The guidelines, the AGA guidelines, still don't support a lot of evidence as to when or how much or what would be a level you would start it as. So this is in adults. So yes, I spent my last hour telling you that this is something that we should be doing, but we still need more data to tell us exactly when to start and where to maintain this. I think this is a very promising area, and soon we'll be able to find it, or at least extrapolate from our adult colleagues, if not do it, not have great data in pediatrics, but I don't know. And I think that holds true for so much stuff in this complex, liver failure kit, that we don't know, but at least we have some direction to go.
All right. That's good. Well, I think it looks like we've had
I think there is one in the question.
Section. So Dr. Billington asks, can you comment about some of the unusual situations of dyscoagulable state sometimes seen in newborns, and whether they have any special considerations for TAG or other liver monitoring that we should be aware of? For instance, newborns undergoing cooling for HIE, what about during hyperammonemic crisis?
Yeah. So the only thing that we know so far is they are a little more coagulable than adults, and that only applies to the neonates. Their INRs can be higher, although still within normal limits, compared to where, and that can be higher in just normal state compared to adults. We don't have much data to comment on, the cooling protocols and HIE and the hyperammonemic crisis, unfortunately. I'm really sorry, I don't have much data in those little ones. It's just so hard to study, and it's rare to study. So no, we don't have much data there.
Right.
Oh, I think Hassan asked about viscoelastic testing available at Masonic and the time frame for return. So I don't think it's the best form, but I might defer this to Katie. I've only been here a few months and haven't had to use it yet. But Katie, do you know if
No, I wonder if either if any of the hematologists might know.
From what I don't know what is available here, and I'll find it and maybe send you a follow-up for that. But I know in majority of children's hospital we use the Coagulation the tags, because the other two can give you falsely hypercoagulable states, especially in littler kids. And I mean, I'll figure it out, and if we don't have, it might be something that we should convince our lab to get. Oh, Dr. knows tag is available. Thank you.
And it's actually pretty quick turnaround now that I think about it. I feel like.
I think the struggle and what we should all aim for is asking the lab to give you the actual tracing, which in my experience, you get the parameters really fast, but the actual tracing, needs to be uploaded. And what I have done in past is when we are actually transplanting kids, we have somebody who just run downstairs and get the actual paper for you to look at the tag, because the time it takes in getting it uploaded and scanned and you can see is does not make it worth it.
And I guess so Dr. Lone said in the PICU, there, or in the CDICU, there's actually a computer that can look at the tag printout.
Yeah.
Yep.
Thank you.
And again, also, so you just have to know who to ask. Great. All right. Just making sure. I think there's a little delay on my computer, making sure nothing else is popping up.
And I did not want my email to go on YouTube, but you can all find me and email me if there are any follow-up questions or anything comes up.
Great. Well, thank you, Haley. It's been wonderful, a great presentation, and just more food for thought on liver disease and how complex it is.
Thank you.
Oh, Emily, we can't hear you.
Emily seems to be stuck.
Yeah.
Emily, you can't unmute yourself? There you go. I think Emily probably wants to say thank you to everyone for attending, and we will see you all next week, okay? All right, and she's waving goodbye. Thank you.